Welcome back. I've got a few questions here. We're going to split this into a couple different sessions. So we go through here, and the first one is Lauretta asks, "Hi, I am taking 15 pumps per day, I guess, of the ValAsta for a stage 1 endometrial polyp cancer, which was removed during a biopsy. I am postmenopausal. Treatment is to have a full hysterectomy. I am opposed to removing healthy organs. I am asking if ValAsta is my option to surgery, and is this enough to kill cancer cells that they may say might have been missed during the biopsy? I'm doing everything I can to reduce the CRP to 3 or less. Second question, is cancer genetic? The cancer teams seem to think mine might be." ValAsta is not an option to surgery. ValAsta is only going to stop the progression of most cancers or inflammatory disease. It is something you want to try before you do something as permanent as surgery, to see if you can get a positive effect from the ValAsta that might be able to change your decision on surgery. My advice is, if ValAsta is going to work, you'll know within 60 days. You should see some improvement in your blood work, in some shrinkage of the cancer. You should feel better, your appetite. You should see symptoms after that 60-day period. If the ValAsta is not going to work, surgery is always an option. So just keep that in mind. Surgery is very matter of fact. It is, once you've done it, you can't come back. You can't change it. So it is something to consider with the deepest, most information and thought that you can. If there are some cancer cells there that they missed, you can usually pick that up with the CA number, your blood work, keeping your CRP to less than 3 milligrams per liter on the your lab work. But you've got to go by the way you feel and by a lot of times the scans. But the CA, the cancer antigen numbers, are very good. I'm not interested in the absolute number so much as I am the trends. So we want to look for a downtrend, obviously, in the CA numbers. We want to see a downtrend in the HSCRP numbers. Alkaline phosphatase is another one. Second question, is cancer genetic? As a blanket statement, cancer is not genetic. You may be predisposed to cancer, but it does not mean that you're going to get cancer just because you have a genetic predisposition to cancer. A lot of people have the ability of cells to mutate, but not everybody gets cancer. So when the oncologist tells you that you have a genetic marker for cancer, it doesn't mean you're going to get cancer. It just means you have a genetic marker for cancer. There's several other steps in the pathway to move from a genetic predisposition to cancer to actually presenting with cancer. Cancer, believe it or not, is very, very rare, and it's something to consider. But the way it moves from a genetic predisposition to cancer is through an inflammatory response. So there's several steps in between, and we have to be able to mitigate those steps to reduce the probability of you being more predisposed to getting cancer. The CRP is the quickest way of doing that. Watching your diet, maintaining a low C-reactive protein of under 3 milligrams per liter is a very good indicator. Making sure that the habits that you had in women prior to age 40 and for men prior to age 50, those habits that we had early on in our 20s and 30s, we got away with. Whether it's smoking cigarettes, drinking alcohol, diet. After those ages of 40 in women, 50 in men, we lose the ability to mitigate those habits and the damage caused by those habits. So deeply consider those things that cause inflammatory disease in your diet. Vegetables are absolutely crucial part of your diet. Protein is also another one. I suggest chicken or fish with maybe periodic red meat. Minimize the amount of high fructose corn syrup or fruits that you eat. So even though, and this is what is going to cause the conflict, the cancer teams look at that and say, well, you're predisposed, and then out of that predisposition in your genetic markers, they're going to prescribe cancer treatments. Be very, very careful. Just because you have a genetic marker, don't let the oncologist use that as a weapon to justify putting you on chemo. Billy asks, I've currently been taking ValAsta for my skin cancer metastasis. I'd like to know what that is, if it's melanoma. I'm not seeing a doctor. I think it's working based off of how I feel, however. I had a few spots in the kidney that are small, but my kidney function has declined a lot. That would make me think that it may be melanoma we're talking about here. Taking things to help it, including ValAsta. In scientific terms, how do you think ValAsta helped your mom's kidneys? Is it possible that helps to rejuvenate the nephrons? Thanks so much for everything, Billy. Okay, kidney function is caused, or kidney function decline is caused by a number of factors. A virus can affect it, bacteria can affect it, waste products, increase in waste products can cause kidney failure. The one thing to keep in mind is the kidney is a filter, and there's a little functional group in the kidney called a glomerulus, and you don't want to plug that up because that ends up monitoring and maintaining your salt balances between sodium, potassium, magnesium, and calcium. So the glomerulus is really important. Now, with cancer, cancer is very efficient at producing large amounts of unusable proteins. The RNA in a cancer cell produces misfunctional proteins that have a tendency to plug up, or it actually accumulates in your arteries, in your veins. These proteins will have a tendency to move into the small capillaries where everything gets choked down to a very small diameter. These proteins can eventually plug those capillaries and cause organ failure. So those things that cause kidney function failure can be cancer. You can have cancer tumors in the kidneys that will have a tendency to shut down the function. And there's a couple reasons for that. One is chemical, one is physical. So you can have a chemical increase in protein levels that plug up the glomerulus or plug up the little arteries that feed the kidney, which will eventually lead to inflammation of the kidney and kidney failure. The other one can be from a tumor, can be strictly a static function where the tumor is putting pressure on a certain area of the kidney. So if that happens, then that part of the kidney can have its blood supply reduced. There's several other functions. You can have your ureter and some of the other plumbing inside the kidney that becomes plugged and stops the flow of urine. When the urine backs up, the pH of the urine can vary from anywhere from about 4.8 to as high as about 10, I guess. So that pH change from acid to alkaline can have a very detrimental effect on the function of the kidney. That in itself can cause a rapid kidney failure. I'm not aware if it's possible to rejuvenate the nephrons. I just don't have the information that would do that. The body's pretty good at repairing a lot of damaged areas, but nothing comes to mind as repairing of the internal workings of the kidney. And in the glomerulus as a structure itself, it's very difficult to repair that tissue that's been damaged. I hope, Billy, that's answered your questions there. The ValAsta will stop the inflammatory response in the kidneys and hopefully will stop the progression of further kidney failure. With regard to my mom, we stopped her. She had kidney failure due to insulin. She was a type 2 diabetic. So when we began to put her on ValAsta, her type 2 diabetes went away, and that stopped the protein and the kidney failure, protein buildup, and the kidney failure at that point. So hers was a little different. It wasn't cancer related. Wajid asks, my mom's been on ValAsta starting 3rd of January this year, initially with 8 pumps per day to currently for 3 months now at 18 to 20 pumps per day. I'm not sure how far ValAsta is helping my mom with her cancer, but I strongly believe it's helping her to minimize the toxicity of the chemotherapy drug. That's a point I want to come back to. She has HER2 metastatic breast cancer with mets to the liver. Diagnosed in December of 2021, the liver lesion size progressed over time on chemotherapy. Looks like it went 13, 27, 35. I'm sorry, it went from 13 to 27 on the PET scan and from 23 to 35 on the ultrasound. Okay, I remember watching Sam's videos where the PET scan or CT scan can't differentiate between dead cell and inflammation debris versus the live cancer cell or tumor. I'm going to stop right there. The PET scan and the CT scans cannot differentiate between the inflammation, which is live cells that take up sugar for metabolism, and the cancer cells that take up sugar for metabolism. There's some articles that's coming out with the NIH to support that premise. They actually find that the inflammatory cells take up the glucose faster than the cancer cells do. So if you have inflammation, it's possible that it will light up very severely, and your oncologist is going to say, "Oh my golly, you have cancer," when in fact it's truly just inflammation. So there's a lot of work that needs to be done here on new techniques to more easily confirm whether it's inflammation or cancer. Up at the top here, it says here about minimizing the toxicity of the chemotherapy drug. We have very new information coming in that the effect of people on chemo and taking ValAsta are seeing very, very good results. It's almost as if it's a two-frontal attack on the chemo or on the tumor cell. One from the chemo side, which is a separate pathway than the ValAsta. But the cancer cell looks to have a very, very difficult time in defending against that two-pronged attack. And there's some papers, for example, using gemcitabine with astaxanthin. They found a tremendous advantage with pancreatic cancers. We're now seeing it with some of the immunotherapy medications along with ValAsta, and they're two separate pathways of attack. So it's very possible in this case that we have something that is 1 + 1 = 3. So it could be very, very positive, and we're going to be watching that very, very carefully. Her CRP was less than 6. That's still a little high, and CEA was at 22. Okay, that's trying to think what it is for her age. But that's still not worrisome. Does ultrasound differentiate between the dead debris versus live cancer tumor? ultrasound is not good at all at finding cancer. That is, it'll show a mass, but you're not going to be able to differentiate between inflammation, cancer, or dead cells with ultrasound. Secondly, if I believe it to be dead debris, not the live cancer cells or tumor, then why doesn't it stay the same size, and why it keeps on increasing over time with each periodic scan? Okay, there's two things that can be going on here. One is your inflammatory response. If you're running a CRP of 6, that means you're still operating at a fairly high inflammatory response. So the inflammation cells around it could be increasing in size, trying to dissolve and attack the cancer. The other option is that it is in fact live cancer cells that are growing. Very, very difficult to sort this out. We've got to look at your CA numbers. We've got to look at your other symptoms. For example, your appetite, your sleeping pattern, your weight loss, to see if in fact it is cancer. Cancer will cause all those things to happen. But this is not a hard science. It's something that you have to watch very carefully. But if you're feeling well and your quality of life is good, chances are it's not cancer. Cancer doesn't behave that way. The next line, it says, overall, my mom's feeling good and getting good sleep, but the scans keep me worried. How long will it take ValAsta to work for late-stage HER2 metastatic breast cancer with liver mets? There's a couple things that people are getting confused about. If you start to see spots on the liver, it can be from supplements. It can be from chemo. The liver gets the bad end of the deal here when we do things like overdose with supplements, take chemo, take radiation. All of that inflammation appears to really show its ugly head in that liver area. So your ALT, your AST, and some of your liver enzymes will kick up. You may even see a spot that might be a fatty liver deposit from inflammation, not necessarily from cancer. The only way to find out for sure is a biopsy, where you go in, you pull a cell out, and you look at it. How long does it take ValAsta to work for late-stage HER2 positives? It's a guess. I really don't know. We have people who see no response at all, to people who see a dramatic response within 60 days. So there's other things here that we need to look at pretty seriously. But I have a real fundamental issue with estrogen and estrogen receptors, and something doesn't make sense to me here, because when estrogen is the highest is when you're in your 20s, but you don't see young girls getting HER2 positive metastatic breast cancers. It only happens typically in women over 40 years of age. There's a few exceptions, but so there's something else that's going on here with HER2 positives that they're not considering, and it's something that needs to be looked at very, very carefully, because there's a disconnect, a pretty serious disconnect, in that why women at high estrogen levels are not seeing these types of cancers, but as women get older, where their estrogen levels are actually dropping, they do get these types of cancers. So it's either at the receptor level that something else is picking up there. As far as recommendations on lowering or increasing the dose, your dosage level's fairly high, and look for the trends. In this case here, she's showing some of the size increases, particularly in the liver area. Make sure that it's cancer. Make sure it's not something you're doing like vitamin C, like supplements. Cut them out. Let your liver heal. every one of those supplements are what's called a pro-oxidant. ValAsta is not. It's the only supplement that doesn't behave as a pro-oxidant or cause fatty liver disease, non-alcoholic fatty liver disease. Vitamin C and fructose are the two that we see the most. We see non-alcoholic fatty liver disease in children from too many sodas. We see fatty liver disease in high-dose vitamin C, vitamin B, vitamin D, vitamin A, niacin. They all go to the liver for metabolic disposal, and that creates an inflammatory response. So watch your supplement intake. I would suggest for a period of time, especially if I start seeing numbers increase like that, that is a measure of inflammation in the liver, and there's something causing that. Especially with her CRP at 6, that number should be under 3 to get these diseases under control. Carla asks, what should I expect from a PET scan, and how would ValAsta affect it? I have had 3 chemo treatments over 7 weeks and been taking ValAsta 10 to 12 pumps per day for 2 months. Will there be uptake in dying cancer cells or only the active ones? Okay, the PET scans are going to show basically the location of living cells in or around that cancer tumor. The PET scan cannot differentiate between what is an inflammatory response from your immune system and the cancer. So that becomes a problem. If they see after chemo that the tumor is actually growing, typically that's going to be an inflammatory response to get rid of the dead cells. Will there be an uptake in dying cancer cells? No. Dead cancer cells are dead. The metabolic mechanisms within the cell have ceased. That's the definition of death. But dead cancer cells bring in your immune T cells that will surround that cell and start breaking it down. And those cells do take in a large amount of sugar or glucose for the PET scan. So even though the cancer is dead, you can still get a positive outcome on the PET scan when in fact your cancer is dead. Only living cells, cancer cells, normal cells, immune cells will take up glucose. That's where it gets its energy from. Also, I've been diagnosed with clear cell endometrial cancer as a primary with multiple bony lesions, including a large tumor in my hip with pathological fracture. Undergoing chemo and will have orthopedic stabilization, including ablation, once this round of chemo is complete. My last alkaline phosphatase was 752. I'm doing 12 pumps per day. Should I adjust my dosage? If so, what should it be? Okay, an alkaline phosphatase of 752 is very, very high. Anything over 120 means that you're having bone loss. Typically, it's going to be cancer or inflammation is going to do that. We are very interested in looking at the trend of that number. So if that number is trending down, that means your bone loss is decreasing. The problem with this is that when the number gets this high, you've lost a lot of bone. And there's going to be pits and marks in the bone. Your bones are going to be very weak. So it is a real problem. It can take years for bone to grow back. At least months. But I would, and during that process, if the cancer is taken out of the bone and the bone begins to deposit calcium, there's still pain involved in that. It's not so much that it's terminal, but it is painful. It's a painful process to go through. 10 to 12 pumps per day, depends a little bit on your body weight. but we want to get the alkaline phosphatase number turned. So if 10 to 12 pumps per day is not tipping over that alkaline phosphatase, then I would go up 25% each month until that number bends over. So if your last one was 752, hopefully the next one's 500, then the next one's 250, and that means that your bone loss is now stopped, and now it's a matter of just rebuilding it. With that, I'm going to stop here, but I hope that's been helpful, and if you've got any comments, please feel free to send them in if I failed to answer any of these questions, or if I need to reiterate those.